Welcome to the Intermacs Pedimacs Database Monthly Webinar. It's Wednesday, January 31st, and we'll go ahead and get started. The agenda for today, I just wanted to welcome, we have from STS, we have Carol Crone, the director of the STS National Databases. We have Leanne Jones, who's the National Database Manager for Congenital CHSD and GTSD, General Thoracic Surgery Database. And we have Emily Conrad, who's our Director of Patient Safety. And we have from Kirkland Solutions, we have Patricia Potter, who's the Nursing Informatics Manager. And we have John Pennington, who's the manager of the data, manages all the data. So today we've got some STS updates, we've got some education involved, and we'll do Q&A as we always do after our education. Just right off, we have some updates. So today's the date. Submit your date by 11:59 p.m. Eastern time today to get all your data in for next quarter's report. Just want to remind everyone the COVID follow-up date exception ended January 1st, 2024. So everyone, we're back into the normal follow-up dates. There is an option on those follow-up forms. If your patients are still doing telehealth visits, you can choose that option, but they must be in the design timeframes, the original timeframes determined by Intermacs. So just some other updates. We have 2024, we have AQO September 11th through the 13th. And it's going to be in Nashville, Music City next year. And it's going to be in person. And we are looking forward to seeing as many people that can join us. And there will be more details coming out on that, I'm sure, later this year. But we look forward to everyone coming out. And that'll be a really fun city to go see. So just a reminder before we get started with our education, just a reminder to use the, this is open discussion. Please use the Q&A function for all your questions. We'll answer as many questions as possible. We encourage your feedback and we want to hear from you. And the next monthly webinar will be February 28th at 1 p.m. Central Time. And the next reporting webinar will be April 18th, 2 p.m. Central Time. We have our contact information, and these slides will be posted probably by the end of the week. You have my contact information and Patricia, and we also have Maceo Clegette's contact information, and he's your resource for all the reports. And so we will go ahead and get started, and Patricia is I'll let her surprise you with the topic for today. And I'll stop sharing, Patricia, and you can do your slides.
Okay, that sounds great. Thanks, Kathryn. Hey, everybody. I'm just going to talk a little bit about major infections. We get lots of questions every day about, whether an infection should be entered or not, and lots of questions about chronic ongoing infections. So I'm going to cover a little bit of educational material on that. Today, I have some slides to share with you all. I just wanted to point out just a couple of things on our appendices. I'm going to share my screen, Kathryn.
Okay.
So if you're looking for resources when entering data, I just wanted to point out the webpage and just show you a couple of things. If you go to intermacs.curso.net and then go to Intermacs appendices, we also have Pedimacs appendices. So if you have any Pedimacs data managers on here, there are appendices with educational resources there. But for this, if you go to Intermacs appendices, we do have, let me see here. Under Appendix A, we have our adverse event definitions. And then all the way down here under Appendix P, we have an Intermacs FAQ User's Guide. So it's the format of, it's our Intermacs User's Guide. And then under some of the material in there, we have frequently asked questions that I try to update quarterly. So if you send me questions and I'm kind of seeing a pattern, I will include that on the next quarter's update. So that's updated quarterly. It was updated just at the beginning of the month. So that is a resource that may be helpful for you when entering data. So I just wanted to point that out. And then I'll go to my slides. Can you see my slides, Kathryn?
Yes,
Yeah, I
I can.
can see them. Thanks.
Perfect. Okay, so we're going to talk a little bit about major infections. We frequently receive questions about infections. The most frequently one asked is, what about an ongoing infection? How do I enter that patient that has an ongoing chronic driveline infection or another infection that's just not clearing up? So I just wanted to point out, we do have information in the FAQ document, but as always, feel free to reach out to me. And Kathryn had shared my contact information. Feel free to reach out to me if you want to run your specific scenario by me to see if you need to enter it or not. We can kind of talk it out, and I'm always happy to meet. So we're going to talk about some infections. So first, going over pre-implant infections. If an infection was present pre-implant, it will not be counted as an infection adverse event unless the infection was treated, cleared, and then recurs at a time later after implant. So just to think of it this way, we are looking at time from implant. So if the patient has something going on pre-implant, it does not need to be entered into the database. Only data that is entered, only data should be entered from implant and beyond. So just a quick little case study. A 75-year-old female with history of non-ischemic cardiomyopathy, hypertension, COPD, and AFib. She has a Foley catheter in place. She develops a UTI 5 days prior to LVAD implant. So that's the key. The infection was before the implant. A urine sample was sent to the lab for culture. It comes back positive for Klebsiella, and she's treated with 10 days of Bactrim. Should this be entered into the database? No, this was a pre-implant infection. It was treated before. She may still be on therapy, post-implant, but it was an infection that occurred prior to her durable LVAD. So no, this would not be an infection that needs to be entered as a major infection into the database. The next question about colonization. If a patient is colonized and as identified by screening cultures, VRE, MRSA screenings, but is asymptomatic and is not being treated for the infection, do not count it as an infection or adverse event. So a case study. A 52-year-old male with a HeartMate 3 in place is admitted to the CICU with a new onset of AFib. Upon admission, the patient had his nares swabbed for MRSA. 3 days later, the nasal swab came back positive for MRSA. So would this be entered? Would this positive nasal swab be entered into the database as a major infection? No, the patient was asymptomatic and was not treated. It was probably just protocol upon admission to the ICU to swab everybody for MRSA or VRE. And his just happened to come back positive. It was a colonization, and he was not actively infected and being treated. So colonizations don't need to be entered unless there is symptoms and or treatment. Multiple organisms. So this is kind of a lot. So I'll go through this and then we'll go through a case study and then how to enter it into the database. So when a patient has multiple organisms, if multiple organisms are identified on cultures from different sources, all within the same 1 to 2 days, if the same type of organism, example, all are different types of bacteria, if it is the same type of organism, this may be counted as one bacterial infection. And for location of infection, select all the locations that apply. And we'll go through that. However, if there are different types of infections identified, like one bacterial, one fungal, a separate infection for each type will need to be entered. And you would select all the locations that were positive for the fungal culture as one infection and all the sites that had a bacterial culture positive for another infection. So a case study. A 68-year-old male with a HeartMate 3 in place is admitted to the CICU with shortness of breath, fever times 3 days, a productive cough with green mucus, and milky tan drainage from around the driveline site. A chest x-ray was obtained, a swab from the driveline was sent for culture, as well as a sputum sample. The sputum sample came back positive for streptococcus, and the swab from the driveline site returned positive for Klebsiella. The patient was treated with IV clindamycin and cefazolin. So how would we enter this? So just to reiterate, the patient had a positive sputum culture and a positive driveline culture. So now you have two different sites and you have two different organisms. One is streptococcus and one is Klebsiella. So both of those do need to be entered. So would these positive results be entered into the database as major infections? Yes. Okay. So on our major infection form, you can enter more than one infection on the form. You can enter a MCS-related infection, which would be your driveline infection in this case, and you can also select a non-MCS-related infection, which would be the pneumonia. So just kind of going down through it. So the type of MCS infection, this was a bacterial infection. It was gram-negative. It was Klebsiella. So that was our driveline infection. Now our non-MCS infection, so that was our pneumonia. That was bacterial. It was gram-positive. Oops. Sorry, guys. It was a superficial percutaneous lead infection. It was the driveline. Did this need to be treated? Yes. It was treated with IV antibiotics. And then for our non-MCS related infection, so that would be our localized non-MCS infection. And if you were to click on show more on your form in the database, it will tell you different types. So this would be like your pneumonia, your UTI. This was a pneumonia, and the patient was treated with IV antibiotics. So that's how you would capture multiple organisms. And like I had said in the earlier definition, if you have a bacterial and a fungal, you can put them all on one form because we have the check all that apply. And then we'll talk about ongoing infections. These are your chronic infections. Got lots of questions about these. So we'll kind of go through the criteria for this and some tips, and then we'll go through a case study and how to enter it into the database. So ongoing infections. If there's an ongoing infection in the same location with the same type of bacteria, enter the infection when it is first identified, along with what type of treatment. So if there's an infection, enter the type of bacteria, and enter the type of treatment. So that would be first. If the intervention documented when the first infection is entered changes, example, goes from oral to topical to IV antibiotics or surgery is needed, then enter another infection adverse event to document the change in intervention. So this would be the patient was identified as having a driveline infection. They came back to clinic. Driveline infection wasn't looking at, the driveline site wasn't looking any better. So they sent the patient over to the hospital, and now they're going from PO antibiotics that they were taking at home to now they're on IV antibiotics. So there's a change in therapy. There was an escalation in therapy. So that does warrant a second major infection form to be entered. Once the intervention is once the change in the intervention is documented, there's no need to enter the infection again unless the infection is treated, cleared, and then reoccurs. So that's if your infection clears up, patient's good, They're no longer showing signs and symptoms of infection. The driveline looks really good. They're no longer being treated, but 1 year later, they're back, in the clinic with signs and symptoms of a driveline infection. Then this probably would warrant another infection because the major infection form being entered because the infection was treated, cleared, and is now reoccurring. And then just real quick on multiple debridements. So if multiple debridements are needed and the infection has already been entered with surgery as an intervention, there's no need to enter a new adverse event for each debridement. So this would be the case if the patient is admitted, they go for an IND, and then maybe 10 days later, they need to have another one. You don't need to enter another one. It's already been captured as surgery as the intervention. So we have a case study. A 72-year-old female with a HeartMate 3 in place is admitted in January of 2024 with increased driveline redness, and it is tender to touch. A swab of the driveline was sent to the lab. The culture resulted in Staphylococcus epidermidis, MRSE. Antibiotics were initiated as PO doxycycline. Would this positive culture be entered as a major infection AE? Yes. So this is the first time the patient has the infection. You enter it as an MCS infection. It's bacterial, it's gram-positive, it's MRSE, it's the percutaneous lead site, superficial, and oral antibiotics were started. So that would be the first infection for this patient. And then subsequent infection in February, the patient returns again with increased driveline drainage that is now requiring dressing changes 2 to 3 times per day. A swab of the driveline was sent to the lab. The culture resulted in a positive culture of staph coagulase. The patient was started on IV vancomycin. So patient in January, they were treated with PO antibiotics, sent home. Things didn't progress very well. Now in February, they're having to change the dressing 2 to 3 times a day. We have a new organism, and now we're going to do a new treatment going from PO to IV antibiotics. So would this second positive culture be entered as a major infection AE? Yes, it would be an MCS infection. It'd be bacterial, gram-positive. This is an other specify type of organism. Again, it's the percutaneous lead site. It's superficial, and then the patient did need antimicrobial therapy. In this case, it's IV. So this patient had 2 infections, both at the driveline, different organisms, different treatment. So that warrants 2 major infection AEs. Now, can you have an infection adverse event without any positive cultures? Yes, but only if the clinical evidence is strong enough. If the patient is having fevers, has a productive cough, chest consolidations on imaging, and is being treated for pneumonia. Even if the cultures have been unrevealing, they're not showing much, but the patient is symptomatic, the clinical evidence is strong enough for an infection. And so that would be a non-MCS infection, pulmonary infection, and pneumonia. So yes, so you can have infections without positive cultures if there is good, strong clinical evidence. So yeah, so that's all I have as far as case scenarios. And if you have any questions, I'm happy to answer any questions you may have. You can put them in the Q&A box.
Thank you, Patricia. That was great. Thank you so much. So now we will, I'm going to go ahead and share my screen again. Go ahead. If you have any questions, put them in the Q&A box. It looks like we have some, so we'll go ahead and get started. Yay, we have some. I'll go ahead and take the first one. Would the same go for COVID? If they were hospitalized for another reason and were found to have COVID, but were not treated or symptomatic, would we not enter an infection AE?
So I would say no. I would say
Right.
no. And this is kind of the consistent information I've been getting. So on our follow-up forms, we ask, has the patient had COVID since last follow-up?
Yeah.
Answer it yes there. But if the patient's not being treated, is not symptomatic, then you don't need to enter an infection, but do capture the positive on the follow-up.
Okay. Thanks, Patricia. And our next question is, will we have access to these slides? Yes, we will. You will have access. It's on the STS website. You can search under Intermacs webinars. I had mentioned earlier, they probably will be posted at the end of the week, probably Friday. If not Friday, surely by Monday they'll be posted. And the webinar along with the slide deck will be available to you. For the onset date, do you use the original date entered first infection always when change of treatment?
No, enter the onset date for infection number 1. So say it was January 1st, 2024, you would enter January 1st, 2024, and then patient comes back in with those multiple dressing changes that were needed, February 1st, 2024, enter that date because it's a new infection.
Thank you, Patricia. And I'm going to let you answer this next one from Hillary.
Okay, Hillary. For the example on major infections where the patient has ongoing driveline debridements for the same infection, I know you said we do not need to enter a new infection event for each debridement, but would you still need to capture each hospitalization event, or do you not enter anything at all? I hope I'm reading your question correctly. So one debridement is sufficient to enter. But if the patient has to be hospitalized
Yeah,
multiple times, each hospitalization does need to be captured.
right. Yeah,
And that goes for ongoing infections. So say there was no change in treatment, no change in organism, nothing is different, but the patient does get rehospitalized, the rehospitalization does need to be entered each time, just not a new infection.
yeah. Thank you for clarifying, Patricia.
Yeah, and Hillary, if that's not what you were asking, feel free to clarify or comment again.
And from Rachel, for some of our patients with chronic infections, they are treated with lifelong oral antibiotics. So we only need to document AE the first time they go from oral to IV. Correct.
Right. Yes, that's right.
Sometimes they're admitted many times and go back and forth oral and IV, but we only need to count this the first time the antibiotics are changed.
No, no. Kathryn, correct me if you
No, I
feel
think, yeah.
differently. If you're going from
Yeah.
oral to IV, it does need to be entered because it's an
Mhm.
escalation. It's a change in
Right.
treatment. It's a change in drug. You know, even if it's the same class of drug, it does need to be entered.
Yeah. Just because it is considered an escalation in treatment. And we've gone over that with our the Intermacs task force. So I know that's a frequent question we've received. And then Sue Ellen, our friend Sue Ellen, when the infection only involves the percutaneous lead, do you enter that the infection is device related?
This is a tough one. Hey, Sue Ellen.
Yeah.
Unless,
Percutaneous lead.
no, unless you're really sure that it is related to the device, you know, you don't know, was the patient not changing their driveline dressing? Was it not being done sterilely? I tend to lean, unless you're 100% sure, I always tend to lean towards no association identified because it's hard to say.
Yeah. Thank you. And then from Louisa, if the COVID infection is the only infection and being treated, should we enter both at main part of the infection form or just the COVID section? So you're asking, do you complete the infection form along with the COVID questions?
Yes, I say
Yes.
yes if the
Mhm.
patient is being treated. So they have, they're requiring treatment, then yes, it should be captured as a viral infection on the infection form. All right. And
Yeah.
then Stephanie. Hi, Patricia. Hi, Stephanie. So to be clear, if an infection is ongoing, same organism, same site, we do not need to keep entering the adverse event. Yes, that's correct. If a patient has another adverse event, such as a GI bleed, we do not need to fill out the form for infection if it's the same ongoing one, right? So, so now you're asking about bleeding. If the patient has another adverse, such as a GI bleed. So the GI bleed, so the major bleeding criteria is a little bit different. So to answer your first question, no, you don't need to keep entering major infections for the same organism, same site. For bleeding, the bleeding does need to be entered. And as long as the bleeding meets the major bleeding criteria, then it does need to be entered. And there are different types. So you would have to look at your hemoglobins to see what type of bleeding it meets.
Okay.
And then from Jeanette, I'm starting to use the customized cohort reports to support our local program, but want to make sure I understand what it is pulling. So far, I haven't been able to make the report match the quality assurance report, a similar time frame and population. Is there a user manual for the customized cohort report?
Um,
Jeanette, I think we have Brian on the line.
yeah, I think this is your lucky day.
So
Hey, Brian.
actually, I would direct people to use the dashboard more than the cohort comparison report. We're currently like that was developed, the cohort comparison tool was developed quite a long time ago. And there's a few things that we're needing to correct in that to make it kind of match our other tools. But if you want to send me an email, we can set up a time to discuss that on your specific use case. John, I don't know if you have any additional details from the data team side.
Yeah, I mean, other than it's been superseded by the dashboard, and you're not the only person who recently has had a question about this cohort comparison tool. We've had internal discussions about that. Like Ron said, there's some things that are kind of out of date there. So I would certainly push you towards the dashboard, but I know some access to that may be limited. But like Ron said, shoot us an email and we'll figure out the best way to get you an answer.
Yeah, and on that note, Jeanette, actually, this is just our next webinar in February. I believe it's February 28th. Devin Cole's actually going to do the live data downloads, go over that. And it's a very helpful tool. So it's a good plug for that webinar, next month's webinar. And Sarah's question, what if they switch PO antibiotics from one to another? Does that still need to be counted as a new AE if there's no new colonization? And the answer to that would be no. Is that correct, Patricia?
Yeah, no.
Yeah, because you're going from one
Yeah.
PO to another. There's not really any escalation. We do have an infection FAQ sheet. Obviously, these slides will be posted. And Patricia, actually, it might be a good idea. We can probably maybe post these under the that Appendix P. You know, when we have our
Okay, yeah,
FAQ. Yeah, we
yeah.
can definitely post these slides under there. So
Okay.
I'll write a note so you'll have access to those there too. An Aaron's question. So to clarify, going back and forth between IV and PO, we only need to add the escalation and not the change to PO each time. Correct. Is that correct, Patricia?
Yes, that's right. Yeah.
Okay, thanks.
And then Jeanette, thanks. Ryan, would you put your email in the chat?
Sure, yes.
Thank you. And then Heather, the hard part with the dashboard is only one user has access. Really wish that could change. Yes, Yeah, right now we are only designating one person per site. If
Yes.
the person that has access at your site isn't the person that's really using it the most, that user can always be changed to somebody else. Just send us an email. Because we did designate the person based on frequency of dashboard usage. But if that changes, or there's a new designation of the site administrator, if that changes and that person needs to have access, we can change who the person is. That is always an option if it's not the most appropriate person.
Yeah, that absolutely, Patricia. Thank you.
Then Stephanie, hi. To clear my second question, if a patient has an adverse event, any other kind, GI bleed, neuro, and they still have the same active infection, does the infection still need to be entered? No, just enter the other adverse event, the GI, the neuro, whatever else is going on. But if it's just noted a continuation of the same chronic infection, just enter the other event. And then Donna, if you have different types of bacterial infections and a different type of antibiotic, but same location, do you enter a different organism, a new infection?
Different
Just trying to
types.
think how this would look on the form.
Yeah.
Yes, you would need to enter each location, each organism, and each treatment.
I want to say, John, and Patricia, did we make a change to that you could add more?
So you can add I know you can do like bacterial and fungal.
Yeah.
And then within bacterial, I'm pretty sure. So I guess it depends on if it's an MCS and a non-MCS.
Right.
Also do a bacterial gram-negative, gram-positive. But if they're both like gram-negative, I don't know if you
Negatives.
can.
Yeah.
Maybe you can. I'd have to look. It might be a select all apply.
Okay. Okay.
But if not, one does need to be, each location and each organism does need to be entered.
Okay. Thanks.
And then Rachel, can you clarify again, percutaneous lead is not a driveline? No, it is. It's a percutaneous lead site infection is referring to a driveline infection. And then you have the option of, is it superficial or is it deep? General question. I'm newer. Sorry. That's okay, Kelly. This is what these
Yeah.
webinars are. Is a driveline infection a percutaneous lead site infection? Yes. Yeah, that's exactly right.
So Patricia, the gram-negative, gram-positive stuff on the MCS infections are select alls. So those are tick boxes. So like they could choose gram-positive, streptococcus, and gram-negative. I'm going to butcher this, Escherichia.
Can you select 2 gram-positives?
Yeah, they're select alls.
So if you select gram-positive, you get the option to select 2 different gram-positive organisms.
Yeah, and then we have a list of a few, like
Okay.
the staff, and then we have the other specified too. So if it's not on our list, they can write it in.
Perfect. Okay, yes. So that will save you from entering 2 different forms. You can
Yeah,
capture.
it will. Yeah.
That's nice.
Thanks. Thanks for looking into that, John. Appreciate it.
Justify being here.
Do y'all have any more questions on the infections? We have some time remaining. Here's one from Rana. Does the previous driveline cite a patient who had driveline revision now consider a pocket wound is not considered MCS anymore, right? Previous DL site a patient.
That would be considered part of the drive. That would be part of the pumps. That would be part of the MCS.
Right.
It is considered as an MCS infection. I know it's pump pocket, not driveline, but it's all part of the device.
Part of it connected.
What else? What other questions are out there? Oh, we got one. Also new to entering data, any way to auto-populate Echo Swan if it's not?
That's a
No,
nice
it's a
way
good
to
question.
slide that in there.
No, we don't carry data forward from older forms, and we don't put like not done. We don't populate the forms with that because something could get overlooked, but it's a good question. Lots of
Right, it
people ask
is.
it.
Yes, it's asked. It's probably one of the most frequently asked questions, and we ask the task force members all the time, and their answer is no, because they're afraid that if you're allowed to, you can just say no to the parent question, then you're always going to do that and not complete the echo and swan parameters. And then Rona said, "Thank you, and thank you for your question."
Okay, Louisa, what if they move the drive line to the left and they have a wound from on the right from the old drive line and that gets still infected?
Huh. They moved the
I
drive
would
line
say
back.
yes, because it was all part of it, and the wound is infected because the drive line was infected. What do you think, Kathryn?
Yeah, I would say so too.
It's a good question, Louisa.
Yeah, it's very good.
Okay, and on that note, if you choose not done on a section, can the other questions related to that test? No. I know
Yeah.
what you're asking,
Yeah.
but like Kathryn said, we don't want to just say no to a parent question and then everything else is a not done. So sorry
Yeah,
about that.
I know it's painful. I understand that. We understand that. But we just want to have some good solid data so we can help these patients, and that's one of the great things about Intermacs, how it's evolved so much in the years, and all the great data that you guys enter into it has really helped this patient population. And then Nancy, I may not agree. If the drive line is no longer there and the wound becomes infected at a later date, that is not the same as a drive line infection. It would look like the new one is infected.
So this is what I'll say to that, Nancy. I agree with you there. If it becomes infected at a later date, no, I don't think that is. But if the drive line has to be revised or moved because it's infected, then I do say that's the drive line infection. But what do you think, Kathryn? Or do we need to take this back and discuss it?
No, I think if the infection was there, I totally agree with what you said, Patricia. But if it's at a later date and it pops up, then correct. And when she says she's a wound nurse.
Then you would know, Nancy.
Yeah.
I agree with you. Later date, yes, different,
Yes.
different.
And jumping in, I'm not as smart as y'all, but by then they would have also done like a device form, right, to show that that component had been removed. So then you have a component removal form, and then later you have an infection form, right?
Yes, you're right, John.
Yes.
And then, thank you, Nancy. That was a good question. All right, from Brooke, for echoes and cats, we only enter the most recent results from the last visit, right? So if you have 2 echoes, use the echo that's closer to your follow-up date.
Right.
All right,
Correct.
and from Sarah, sorry to keep asking about infections. Nope, don't be sorry. It's what we're here
Yeah.
for. I'm still confused. And if an infection never went away and they escalate treatment, do we use the original infection date or enter the date they escalated treatment? So if the infection went away and they escalate treatment, so you're talking about 2 different infection forms. On the first form, enter the date that the infection was first identified and treatment was initiated. So that would be your date number 1. And then if the infection doesn't go away and now they're escalating treatment, that would be your second infection form, and you would use that date, that second date.
The date that you escalated treatment. Correct?
Yes, that's correct.
Yeah. Yeah.
And Sarah, if you're still confused and it's not making sense, feel free to email me and we can talk it out.
And some of y'all may remember back in the day, and John, I think you do, when we had the ongoing box
I feel
for
like I might
infections.
remember that too, Kathryn.
Yeah. So kind of helped with this, but I think we're actually getting better data doing it the way it is now. Just might be a little more confusing.
Another question from Kelly. I have a question unrelated to infection, if there is time to answer. Yeah, plenty of time. Is there a way to get our centers and STS's Intermacs data on survival by device, looking specifically for HeartMate 3 survival? If not here, who can I email to look at this with? I've tried using an outcomes analytics report, but I'm not sure if I'm making the correct selections.
This, I think, is a perfect example of where Kathryn plugged Devin's education on the live data download. She could absolutely get to those answers, Kelly, with your form data.
Mm-hmm.
And so getting it directly from the door form download, you can definitely get to that from the outcome analytics. I think we don't necessarily, was the question identifying HeartMate 3 outcome?
Yes.
Yeah.
I don't think we put HeartMate 3 specifically on there, but we say fully
Maglev.
maglev. So that is just how to get to that without putting the trade name on that tool. So it's definitely possible from that. And then also in the, well, I guess in the QA reports, it wouldn't necessarily be limited to HeartMate 3. But I would say check out the outcome analytics. And then also, if you want to shoot me an email too, I'm happy to look at it directly with you.
It's also in your site data set. So that would depend, though, Kelly, how up to date of data you need. So, if you need to update some forms today and see it reflected, that's not going to be in those site data sets. But if you're good with stuff within like the last quarter, it'd be really easy to get to in your site data.
Oh,
yeah,
and she's asking, HeartMate 3 is continuous flow HML or FML? It's maglev.
Oh, FML. So
FML, yeah.
FML. The HVAD is the other one, right?
Yeah.
And then one of your
Rana?
questions.
Oh, go ahead.
Oh, that's okay. So previous driveline site that got infected at a later date is not MCS related. We'll consider as yes, that's right. Later date, not when it's going on.
Right.
Nancy, does the 1-year follow-up pop up if the VAD is discontinued for recovery or transplant? So it depends when you're entering. If you're entering data kind of backdated and you enter the death after it's generated, it may be there. And just email me and we can remove it. So if the patient is explanted for recovery, transplant, death, whatever is going on and the form is already there, we can have it removed. So it just kind of depends on the dates that you're entering things, if it's there or not. And then Anne, hi Anne, a patient that has a chronic infection with worsening symptoms, PO antibiotics kept changing but not escalated to IV. Do I need to delete these entries as I did enter for each change for worsening symptoms? I'm assuming probably same organism and everything. I don't know, Kathryn, what do you think? Because we say that if it's just a change in PO to PO antibiotics,
Yeah.
you don't need to, but if the
symptoms
symptoms are worsening,
yeah. That's what I'm
more
wondering.
drainage, more tenderness, fevers.
Right.
I would say keep them. What do you think, Kathryn?
I would say because it's got worsening symptoms.
Right.
So that
Even
is
if it was
escalating.
just staying stagnant and not getting better, I would say you could probably not and just leave one AE, but because the symptoms are worsening, that makes me think that it should be entered.
Okay. I agree, yeah, because it's worsening. And then Kelly says, thank you. Well, thank you for your questions, Kelly.
Oh, Nancy, I think you're saying if they're alive. So if they are explanted for transplant or recovery, that ends their time in Intermacs. So that 1-year form does not need to be completed.
But but the 1 year post cessation will.
Oh, I'm thinking 1-year follow-up. Okay.
Were
Yes.
you, yeah, Nancy, I guess just clarify, were you talking about the 1 year follow-up or the post cessation of mechanical support? Guess we just need clarification on that. Because it'd be 2 different answers. And then Anne said, yes, it was the same organism, just escalation of symptoms, worsening of symptoms. So,
Yeah, I'd say leave your entries, Anne, because of the symptoms associated with the change in antibiotic. If you're filling out an adverse event form and the patient is still hospitalized, what do you enter for discharge date? So if the patient is still inpatient from their index or implant hospitalization, you'd have to wait until the patient is discharged to enter the discharge date.
yeah. And most
But
of
I
the
don't
time,
know which one is asking you for a discharge date.
probably the hospitalization form, the
Well, if
the
the
hospitalization form.
Yeah, Kara, if the patient is still inpatient from their VAD placement, you don't need to complete the rehospitalization form, just the whatever form is needed, bleeding, neuro. You don't have to complete the rehospitalization, if that makes sense, because they're already in the hospital.
And Sarah, would you consider moving the uric acid value to be with the other BMP, CMP lab values instead of after the CBC and other miscellaneous values? I can totally understand that.
Yeah, we could do that.
Yeah,
See
we can
if that
definitely
makes
do
the
that.
flow easier going back and forth between lab results.
I'll actually write that down so we can talk about it at our meeting tomorrow.
Okay, that sounds great.
Okay.
And that's staying on the same form and everything. So that's just reordering questions. That would be a pretty easy fix.
Mhm. Okay, Nancy, the 1-year cessation form. So a patient is explanted for transplant or recovery. Okay, I'm trying to remember your question. Does the 1-year post cessation form need to be completed?
Yeah.
Does the 1-year follow-up pop if the VAD is discontinued, explanted for recovery or transplant?
Yeah,
Say
she's
that one
wanting
more-
to know, does the cessation form pop up if the device is explanted for recovery?
Yes, it does.
Yeah.
Yep, because we're looking to see, did the patient, what happened within that year? Did they pass away? Did they get transplanted? What did that year look like for them? And does the modified Rankin scale question on follow-up is the score when they had the initial stroke? Yes, that's correct. And then if on follow-up moving forward, if the modified Rankin scale is reevaluated and the stroke score changes, you can update it, the follow-up form with that value. The adverse event form has a due date. Hold on. It's a readmission, not index. Okay, so the patient, I'm trying to remember your question, Kara. So the patient was readmitted, but you don't have a discharge date, then you would just have to wait until you have the discharge date to validate and submit the form.
Yeah. And I usually just tell sites, I think I mentioned this earlier, just to write it on a sticky note or a reminder, that you need to enter that discharge date, because you can save the form and then enter the discharge date when the patient's discharged.
And then do the same with the LFTs and LDH in the middle of it. Lots of jumping around. Okay, we can
Okay.
look at those and try and make it a little more streamlined so it's not so much jumping around. Thank you. It's a good tip. Okay, for AE bleeding, are we using the hemoglobin count baseline pre-implant or the recent one before the bleeding event? Use the one before the bleeding event, because if it's like 8 years down the road, you may not have that pre-implant hemoglobin. The cessation form pops up right away when entering a transplant or recovery. Are you saying we should wait the full year before complete? No, you can complete the form once you have
Yeah.
the date.
Yeah.
It makes it look like we're not. No, you don't have to wait. As soon as you have the information, you can enter it. You don't have to wait a year. It's just, it allows for a year for it to be entered.
Yeah, what we're trying to do there is within 1 year, right? It's not at 1 year. We want to know
Right.
what happened within that year.
Within that year.
Yes.
Yeah.
Mm-hmm. Yeah. Okay, well, we have time for a couple of more questions. And Sarah, I believe this was answered on the last meeting, but can we, as abstractors, estimate the modified Rankin scale? It's not often done as subsequent follow-up visits, but it's indefinitely required if the patient has ever had a neuro event. That is true.
I say yes.
Yeah,
I think
yes,
if you're
you
getting a
can.
good
Yeah.
picture of what the patient
Mhm.
looks like, and what they would score, yes.
Yeah,
Absolutely.
that's allowed. Well, I want to thank everyone for a great webinar. Patricia, thank you so much for doing the slides and for the presenting the infection scenarios. It was a great webinar. Thank you for asking all the questions. Again, you can contact Patricia and I if you have any more. And it looks like we've got one more. Another cessation form question. If the patient is alive still, do we need to wait longer in the year to see their outcomes to complete the form?
No, if you have a transplant date or a death date, you can go ahead and enter it, because that's all it's really looking to capture.
Right, but she's saying if the patient's still alive, do they need to
Oh.
wait longer in the
I
year?
guess so, yeah.
Yeah, I probably would. But if, as Patricia said, if you know the transplant or the death date, then go ahead and complete it. That's where we allow that within the years John was talking about. Thanks. Looking forward to the slides. Great questions and answers. Thank you. Yes, y'all did a great job. Patricia, awesome. John, Ryan, thank you. Can you show or send us an example of the 1 year post cessation form?
Kathryn, I can share my screen, or
Okay.
you're over. Yeah, I can share.
Yeah, I'll stop sharing. There you go.
Can you see my screen, Kathryn?
Not yet.
How about now? Good?
There you go. Yes.
Okay. So where I was showing you earlier, our appendices, our resources, if you wanted just printable forms or just forms you can look at, under Appendix P, we have all of the forms listed here, and one of them is the 1 year post-cessation form. And like Kathryn had said, this form is intended for patients that are explanted for recovery. So we're looking at, what happened to this patient within the year after recovery. So you can enter your date. And then the first question is the patient deceased? Yes or no? If it's yes, enter the death date and what the primary cause of death is. If it's no, you'll go on to the next question. which is, was the patient transplanted? And if they were, what was the date of the transplant? So this form auto-generates once you enter an explant form for recovery.
Yeah.
Anything
Or
else?
if it was decommissioned.
Yes, turned off.
Yeah.
Yeah.
Turned off. Correct. Thank you for that. I think we had one more question. What is if the patient was decommissioned, should we wait the year? So, yes. Excuse me?
I was going to say, sorry, Kathryn. I was going to say, as long as they're alive, yes, you should
Yeah.
wait.
Yeah, as long as they're alive. But again, if they were transplanted or if they had died, then you would go ahead, and you know that, then you would go ahead and complete the form. Yeah. And I think that's it. I want to thank everyone for a great webinar. Thank you so much. Oh, it looks like we have one more. I will email you, Patricia. We have entered explants and never seen the 1-year post-cessation form. Yeah.
Yeah, email me. Maybe your criteria didn't meet it, but yes, if you email me and send me some patient IDs, I can look into each one and see if it should be there or not.
Yeah, thank you. Thanks, Hillary. Thanks, Patricia. Well, thanks everyone for a great webinar. Hope you have a great rest of your week. And I appreciate everyone joining. The questions were great. Patricia, thank you. This is great content. Thank you for all the STS members, Addie, who I did mention earlier. I'm sorry, from STS, who does the, she also works for all the databases helps with the enrollment and other stuff. And so thank you, Leanne, Carol, Emily. Thank you from Kirkland Solutions, John, Ryan, and Patricia. And Ryan, I missed you earlier too. Thank you, Dr. Cantor, for joining. And again, we will see y'all next month. You can email us with any questions that you may have. And we will talk to y'all later. Thank you.